Hello, everyone. Thanks for joining us. My name is Kaveh Khoshnood. I'm a faculty at the Yale School of Public Health. I'm the faculty director for Humanitarian Research Lab at our School of Public Health. And I've had the pleasure of knowing Professor Claire Greene a long time ago when she was a student, an MPH student at our School of Public Health. Professor Claire Greene is an assistant professor in the program on forced migration and health at Columbia University Mailman School of Public Health. She received her PhD in psychiatric and substance use epidemiology from Johns Hopkins, Bloomberg School of Public Health. And as I said, she got her MPH from our School of Public Health in the Chronic Disease, Epi, and Global Health Department. And she did her postdoctoral training in implementation science and humanitarian health from Columbia. At Columbia, she teaches courses on the collection, analysis, and use of data to improve humanitarian assistance and on mental health and forced migration. Her research focuses on designing and evaluating strategies for improving the effectiveness and implementation of mental health and substance use intervention in humanitarian settings. In addition to her research and teaching, she regularly consults for UN agencies and humanitarian NGOs on the design and evaluation of mental health and substance abuse program. Thank you so much, Claire, for joining us. I'll pass it on to you.
Okay. Thank you. Thanks everyone who's here, and thanks to those online. It's truly a pleasure and honor to be here today. So as Kaveh mentioned, it feels very good to be back here. So I did my MPH here at Yale, and I have so many wonderful memories of my time here. One of them being a photo that's at the top left of your screen. I did my thesis research under the supervision of Professor Trace Kershaw and through the Downs Fellowship, which was led at the time by Kaveh, in China, focused on mental health and substance use and HIV. And the photo just below, on the bottom left-hand side of the screen, is actually my MPH thesis poster presentation, which my parents were so proud of that they actually framed it. And it's been hanging in their basement for over 10 years now. So I guess I owe a big thank you to Yale for helping me make my parents proud. But in all seriousness, it's really a pleasure to be back here. Such fond memories. And really, Yale was where I discovered the fields of humanitarian health and mental health and their intersection. I worked with a postdoc at the Macmillan Center on a review trying to understand the alignment of mental health interventions that are implemented in practice and those that are researched. And perhaps unsurprisingly, the evidence we have does not align very well or didn't align very well with those interventions that are actually implemented in practice. And for me, this is really what sparked my interest and motivated me to move along this trajectory in mental health and humanitarian settings, which is one that I'm still motivated and excited by today. So a big thanks to Yale and to all of you. All right, so I thought I'd start just by talking about why we should care about mental health in the context of humanitarian settings. Kaveh and I were just talking about how there's such a plethora of health needs in these contexts. But for me, I think there are a few reasons why mental health should definitely be an essential part of humanitarian assistance. The first is just thinking about the burden. So the best estimates we have suggest that 22% of people in conflict-affected settings have a mental disorder. That's more than 3 times higher than the general population. We know that even beyond that, people in humanitarian settings experience elevated distress, and that affects their functioning and their well-being. So there's a lot of people affected and who could benefit from mental health and psychosocial supports. We also know that people in humanitarian contexts have very limited access to services. There are not a lot of specialists, not a lot of mental health providers. Fewer than 10% of people in humanitarian settings with a mental health problem access services. We also know that outside of the formal services system, a lot of the community and informal supports and protective practices are disrupted in emergencies and when people are displaced as well, which further increases the risk of mental health issues. So I thought it would be helpful to provide a little bit of a historical context here, because I think it highlights where the field has been going and where we are now and where we need to be going in the future. So it really wasn't until the late 1980s that humanitarian actors first convened, at least on record, to discuss mental health needs in the humanitarian context. And this happened in a refugee camp in Thailand with refugees from Cambodia, where according to these humanitarian actors, they noticed a deteriorating social condition that needed to be addressed within this context. Move forward 1 decade and we have the first evidence of psychosocial interventions being applied in a humanitarian setting in the context of the conflict in the Balkans. And then it wasn't until 2007 to 2009 that we started to get guidelines and really formalized recommendations around how to respond to the mental health and psychosocial needs in humanitarian settings. The publication of the Interagency Standing Committee Guidelines on Mental Health and Psychosocial Support. We also saw that during this time, UNHCR added mental health conditions to their list of the list of conditions they captured as part of the health information system. Prior to 2009, there was essentially no record of people seeking support for mental health through the primary care system. And then in the 2010s, we started getting information and guidelines around how to integrate mental health and psychosocial support, which I'll start referring to as MHPSS because it's a mouthful, across different sectors in protection services and primary care and other settings. So since 2010, there's really also been this proliferation in research on mental health or MHPSS. As you can see here to the right, these are the publications in PubMed that include mental health and humanitarian settings. And you see this rapid increase after about 2010 in the amount of research being conducted on this topic. In parallel, we've also seen the development of various resources to support the implementation of MHPSS in emergencies. WHO has invested a lot in developing these scalable psychological interventions, which are manualized interventions, evidence-based interventions that can be delivered by non-specialists in order to address that gap I mentioned between access to specialized mental health providers in these contexts. And I think the good news here is that we have effective mental health interventions. This forest plot on the upper right-hand side of the screen is the result of, or are the results from an umbrella review or a systematic review of reviews, where they've essentially found that in humanitarian settings, we have pretty good interventions that seem to work, particularly in adults, to address issues like depressive symptoms, anxiety symptoms, post-traumatic stress symptoms, and distress. There's also been a lot of investment in implementation science and trying to understand how can we overcome some of the barriers that exist to delivering and accessing mental health and psychosocial support in emergencies. So all of this is very good. But one of the things that I've been thinking a lot about and that I think motivates some of the work I'll share with you today is why haven't we seen this evidence really being translated into population level impact? Why is it not being adopted within the humanitarian sector? And I think there are a few reasons why we haven't yet seen kind of the translation of this evidence into improvements in population level well-being. The first is that many of the interventions we have, their effects are short-lived. So often we see that people, when they're in, say, a group-based intervention over 8 weeks, they tend to improve. But after that intervention ends, they often return toward, maybe not fully, but regress a bit as far as their mental health conditions. We also know that evidence-based interventions are often not adopted or sustained within routine services. So a lot of the evidence is generated within the context of research, and it's challenging for various reasons to actually integrate that into routine care delivery systems. And then the third point here, which I think is really central to my talk today, is that many of these interventions really do not consider the contextual, structural, or social determinants of mental health, which we know are so important to people's lived experience and well-being. So this is why I present to you what I think is the rationale for multisectoral interventions. And what I mean by that is, first, we know that mental health is a central part of people's lived experience. We also know that it exists within the context of many other factors, and these are just a list of social and structural determinants of health and mental health that we see in the literature, but also from some of our formative work that relate to the mental health and well-being of forcibly displaced persons. But if we think about mental health as operating in a vacuum by itself and ignore these root causes and these risk factors for mental health problems, how would we expect perhaps that the intervention effects that we're trying to test can be sustained? So we did a survey with 225 refugee and migrant women in Ecuador and Panama, trying to understand what are the factors of your lived experience that relate most strongly to your overall well-being and life satisfaction. And what we essentially found was that people's sense of safety and their standard of living were most strongly correlated with their overall well-being and quality of life. This probably isn't so surprising for many people, but what I think is important to note is that these are not usually the focus of our mental health and psychosocial interventions. Often our interventions are focused very much on our thoughts and our feelings, our behaviors, our interpersonal relationships. But if really at the root of people's well-being is their sense of safety and protection and their standard of living, are we missing the mark by thinking kind of too narrowly around what's happening immediately in people's minds and in their kind of immediate circles and relationships? Not to undermine or discount those, they're important aspects of people's well-being, but I think what I'd like to argue today is we need to think a bit more broadly. And so part of that is highlighted in this figure here. So if we are able to address people's mental health with these interventions that I've shown you that are effective, that people are operating and returning to contexts where all of these risk factors continue to be present, can we really expect that those mental health effects will be long lasting? So I'd like to start today just with an example of a study that we did a while ago now that looked at this intersection of intimate partner violence and mental health in Nyarugusu refugee camp in Tanzania. So Nyarugusu is a refugee camp in Western Tanzania that was established in the mid-1990s. At the time we started the study in 2014, there were 65,000 registered refugees living in the camp, primarily from the Eastern DRC. And just a little bit of context here, refugees who are living in Nyarugusu have really a lot of restrictions as far as their mobility. They're not allowed to leave the camp. They also are not able to work. There are a lot of restrictions. They can't get formal employment. A lot of their livelihood opportunities are really restricted. And I think that's important context when we think about their risk for both intimate partner violence and also mental health conditions. And we'll see how that plays out in just a minute. So within this context, intimate partner violence, or IPV, is one of the main protection priorities recognized by UNHCR in Nyarugusu. It's well kind of acknowledged that it's a prevalent public health condition affecting many of the people in this setting. We also know, based on data from the camp itself, but also some more kind of rigorous data from population-based surveys in the Eastern DRC, where most of the refugees are from, that IPV is one of the leading risk factors for poor mental health among women of reproductive age. So here's some data from this household-based, population-based survey that was conducted in the Eastern DRC that shows essentially that women with a history of IPV have roughly a twofold increased likelihood of having depression, PTSD, and suicidal ideation or lifetime attempts. We don't see the same pattern for substance use. However, I think it's pretty consistent across a lot of these other common mental disorders to see that there's an increased risk here associated with IPV. So within Nyarugusu, the approach to addressing these related conditions is pretty siloed. So on the one hand, we have the protection actors, and at the time it was the International Rescue Committee, managing a lot of gender-based violence prevention and response programs to address IPV. And then we also had some health actors focused on addressing the mental health and psychosocial support needs through the Tanzanian Red Cross. These services were separated at multiple levels. So they were largely siloed and not very well coordinated. And so essentially what this means is if, say, there's a survivor of IPV with mental health needs and she goes to the Red Cross to get mental health care, those services are often not very well coordinated to address the GBV or IPV needs as well. So our goal with this study was to see, can we test an integrated intervention that simultaneously aims to address intimate partner violence and mental health in order to improve kind of the synergies between these two multisectoral approaches. We started off this study by doing some formative research to understand what are the salient mental health and psychosocial problems affecting survivors of IPV in Nyiragusu. And we used two methods. We used free listing interviews, which are a rapid qualitative method often used to identify a list of concepts and prioritize a list of concepts or problems in a community, followed by some in-depth K-informant interviews to better kind of flesh out and describe the priority mental health problems that we identified as affecting IPV survivors in this context. So the results of this formative research process revealed really three key mental health and psychosocial problems. The first was stress or too many thoughts. In Swahili, it was msongo wa mawazo, which was really described as those internalized feelings of distress. And then we had this concept of huzuni or deep sadness, which is more of this externalized presentation of distress. So feeling really angry or aggressive or upset. And the third mental health problem that people described as affecting survivors of IPV was fear or hofu, which was characterized by worry, trembling, or fearing that something bad was going to happen again. And so these data were really helpful for us because we were thinking within the context of an integrated intervention, perhaps the mental health component could focus on these three priority mental health conditions. The other part of our formative research and a really key aspect of this multisectoral process was thinking about where to position this type of multisectoral intervention within the refugee camp setting. And we went through a process of community mapping, which first involved like physically mapping who are the stakeholders involved in these two activities in MHPSS support and GBV response, and where are they physically located in the camp, which is the map on the left-hand side. And then we also went through a process of doing some focus groups with people in the community, with community leaders, with humanitarian practitioners to understand how people navigate these different systems and services and that are available to them. And what I think is really interesting, what was super helpful and critical about this process for us is you can see on the right-hand side in blue are those kind of formal actors or the formal system where you have the protection providers that do the GBV response and prevention programs like the IRC, you have the police, you have case managers, legal services, and health services. But what we didn't discover until we did those focus groups, or even from talking, after talking with the humanitarian actors, we didn't yet know of this entirely, this informal system. And so essentially why this is important is that for IPV survivors, it's expected and really only culturally acceptable for that problem initially to be aimed to be resolved within the family. And so it's really looked down upon, and there's a lot of stigma associated with going directly to that formal system. So most of the survivors of IPV are still operating within this informal system of support through the family, and only if the family is not able to resolve the issue can they start engaging with neighbors, with the local police force, with village leaders, et cetera, et cetera. So for us, why this was important is that if we only thought about reaching women within the formal system of care, we would have missed a lot of people who could potentially benefit from an integrated mental health and IPV intervention. Please, sorry.
But the fact that they go first or try to resolve it into the family, isn't that due also because of the availability of the other more formal services or more on a continuous basis?
Yeah.
Accessibility as well?
It's a great point. Yes, certainly. I mean, the access to services, specifically access to justice, was really limited. And so the use of these local courts and village leaders was really essential for that purpose. The way it was described to us primarily was related to the stigma with actually seeking services through the formal system. There were social consequences of doing that, unless it was kind of permitted, I'd say, by some of these informal actors. But certainly access and availability is another challenge as well. Thanks for that question. So with that information, we designed what we called the Nguvu intervention. Nguvu is the Swahili term for power or strength. It was an 8-session intervention that combined cognitive processing therapy, which is a psychological intervention designed for survivors of trauma that fit nicely with those problem areas we identified in the formative phase of the research. And we combined cognitive processing therapy, which I should also mention had been previously tested in the Eastern DRC. So there was some already cultural adaptation that was done that we felt needed an appropriate intervention for this context. And we combined that with advocacy counseling, which is an intervention that has some evidence for reducing kind of the chronicity and intensity of IPV among women who've already experienced some form of domestic violence. As far as the implementation, this photo is a picture of our research and our intervention counselors. So our research assistants and intervention counselors in Nyiragusu after one of our trainings. So we use this task sharing approach where we hired a team of volunteers from the community or incentive workers. They were given a very small incentive to work with the International Rescue Committee to do some community outreach as part of the GBV response. And we worked with this cadre of women and trained them in this intervention so that they could provide it within these community settings, kind of integrated within IRC's broader GBV program. The intervention itself involved one individual session followed by 7 group sessions. And again, we integrated it within IRC's Women's Protection and Empowerment Program with the intention of kind of fitting it within an existing system of care that women were already comfortable participating in. So the Women's Protection and Empowerment Program was not specific to GBV. It was a service that was provided to women. It was not a stigmatizing place for women to go. And if they participated there, they wouldn't necessarily be identified as someone who was a survivor of IPV, which was a key protection concern for us. And then finally, going back to our discussion around the informal versus formal systems of care, we ended up recruiting women through community-based women's groups so that we could reach a broader number of women from community settings instead of relying just on those who were accessing services through those formal channels. As far as our study design, we conducted a cluster randomized trial where we randomized those women's groups from which we recruited to receive these Nguvu intervention or to receive IRC's usual kind of care program for GBV survivors. And we were specifically looking to enroll adult Congolese refugee women in Nyiragusu who reported past year experiences of IPV and moderate to severe psychological distress. The outcomes that we measured at baseline and then 1 week after the intervention, so that's about a 10-week period, were anxiety symptoms, depressive symptoms, symptoms of post-traumatic stress disorder, and then the frequency of physical, psychological, or sexual IPV. So just to characterize the sample at baseline, we ended up enrolling 311 women in the study. They were about 33 years of age on average, had lived in Nyiragusu for 17 years on average. This is really a protracted emergency setting. A lot of our research team, in fact, had been born within this camp. A lot of people had lived most of their lives there. 2/3 of the women in our sample were married and living with their current partner. And as far as their mental health, this profile is largely by design because they were required to have at least moderate symptoms of distress in order to participate. But you can see kind of pretty similar levels of anxiety, depressive, and PTSD symptoms that are between a moderate amount and a lot of symptoms over the past 2 weeks. And what I think is really troubling but important is just looking at the profiles of IPV as well. So the requirement for being eligible for the study is that they reported having experienced some form of IPV within the past year. But as you can see, the majority of women who participated reported having experienced sexual, physical, and psychological IPV within the past year. And it was actually quite rare that women reported not having experienced sexual violence perpetrated by an intimate partner. As far as our outcomes, so here we conducted mixed effects models to look at the difference in change from baseline to follow-up between our Nguvu condition and those who received or were referred to usual care. And what we ended up seeing, these are just effect sizes to kind of visualize the changes over time. We did see that women who participated in the Nguvu intervention showed significantly greater reductions in depression, anxiety, and PTSD symptoms. We did not see any change or any significant change as far as IPV between the usual care and the Nguvu condition. I did just want to go on a brief tangent about measurement of mental health because I think it is important and actually one of the most surprising and interesting findings for me as part of this study. So one of the things that I mentioned from the beginning is after having gone through that formative research process, we decided that those three concepts of distress, hofu, msongo wa mawazo, and huzuni, looked roughly like anxiety, depressive, PTSD symptoms. And so we perhaps naively selected some research tools to measure our outcomes that corresponded to depression, anxiety, and PTSD. And so what we did after the fact is we wanted to say, okay, let's look and see how our data cluster together. What are the factors, the underlying mental health conditions, and how these symptoms of mental health problems correlate with one another. So what I'm showing you on this slide are the items. So each of those words corresponds to an item on one of those measures. The gray items corresponding to depression, red for anxiety, purple for PTSD. And if we did a kind of looked at the factor structure, and if these three conditions were valid in this context, what we'd expect to see is that the depression items would be more correlated or clustered with one another, similarly with the anxiety and with the PTSD items. So we did an exploratory factor analysis, and what we ended up finding was something more like this. It's like a random mixing of symptoms across these three conditions that no longer looked like depression, anxiety, and PTSD. So at first we sat there and were kind of stumped. We didn't know what to make of this. We tried to say it was just some strange statistical issue, who knows? But after spending some time with this data, what we ended up seeing is that these problems almost perfectly aligned with those three initial concepts of distress that were described to us by the women we interviewed in that formative process. So for me, what I take away from this, I mean, we know that mental health is really difficult to measure. We don't have gold standards. We know there's cultural variation in how mental health conditions present. But I think the bigger piece and the bigger picture here is just the importance of listening and trying to avoid applying our perspective and a worldview that's familiar to us on the data that are presented. Because I think perhaps naively we had done that in the situation and kind of forced what we were hearing to fit something that was familiar. When in fact, I think we saw this amazing triangulation of our qualitative research and our quantitative research telling us something quite different. All right, so back to the study and the relation with multisectoral interventions. I just shared with you the main results from the study, but if we pull back the curtain a little bit, as always, it was a bit messier. There were a lot of implementation challenges. We had a lot of issues with staffing and kind of coordination and organization and all of these other factors that come up in most research projects, I hope, or not I hope, but I bet. And so we took some time to conduct a process evaluation, to do some interviews with different stakeholders who participated in the study, those who were a bit external to the program, some focus group discussions. And then we also collaborated with a group from the Global Health, Justice, and Governance program at Columbia to do a funding analysis and look at policy documents at the same time the study was conducted to try to understand what factors might have influenced the implementation challenges that we faced. And what we came up with was a model. This is a very simplified version of it. The full version's in the paper that you probably aren't able to read, but I'm happy to share the slides with you after. We came up with a model that identified kind of multi-layered determinants that probably looks very similar to the social ecological model for many of you, that influenced the ability to integrate our GBV and our mental health components of this intervention. So just to go through these quickly. At the structural level, I mentioned at the very beginning some of these complex policies related to freedom of movement, ability to kind of earn a living and participate in livelihood activities. And this policy landscape and the broader context, I think, really made it complex for us to address these related issues, because in many ways, those structural factors really reinforced some of the risks for both GBV and mental health problems. We also found, and related to your earlier question, that in the legal system, there were few protections against GBV and access to justice was quite limited. there was a legal officer who would come into the camp a few times a week to work with people on cases, but it was really expensive. It took a long time. There were a lot of factors that made it hard for people to access that type of support if they wanted to and felt it was acceptable to do so. Also, mental health services were just limited. It was not prioritized in the camp. There weren't a lot of resources available to address mental health needs. And I think a lot of this was ultimately really aggravated by the funding environment. So funding for GBV and mental health are very separate. And this made it quite challenging for us to actually convince people funded from the mental health actors and those funded by the GBV funders to work together and to try to achieve kind of shared or respective goals. Not to mention that a lot of the funding requests were not fulfilled. So while GBV was prioritized, the funding was, I think, only 40%, or the appeal was only 40% funded, and expenditures were half of what they actually expected. So really under-resourced as far as the projected needs. Another challenge at the next level was just interinstitutional coordination. And I think this is a huge challenge in the humanitarian sector in general, just coordination across the board. But surprisingly, even between MHPSS and GBV actors, coordination was very limited. We found that there were working groups operating in the MHPSS space and the GBV space who would say, we know the importance of the other, we know that this is related to what we're doing, but there was very little actual talking or no joint action plans about how these two sectors, two areas would work together. We also found that within the GBV plan, it included an element of psychosocial support, but not really any operationalization of what that was. It was just this mandate, or this recommendation, I should say, to provide psychosocial support, but with very little guidance on how to do that. And similarly, within the MHPSS working group, which was designed to be multisectoral or cross-sectoral, the actors involved were largely working within the health system as opposed to engaging with the protection sector. I don't know how to solve this one, but if people have ideas, I'd love to hear them. So at the next level, we have the intra-institutional context. And this was where I think we most acutely saw some of our challenges. Within the organization we were working with, there was a really high rate of staff turnover at all levels, from headquarters down to the field staff level. And this made it challenging for us to have kind of reliable engagement and buy-in from our partners, because it varied based on whoever was the decision maker at that point. And I think ultimately made it really difficult for our counselors to know who they were accountable to or what they were accountable to. Another challenge, as I mentioned earlier, is that given the siloed funding and the project-based funding that exists in the humanitarian sector, a lot of, or the recognition that it made sense to integrate mental health and GBV was often kind of overcome by the need to be accountable to whatever the objectives were of a donor-funded program. And so there was just a lot of competing priorities and challenges in terms of adopting and being more flexible about this intersectoral approach. And then finally, at the community level, I think the main takeaway for me is that women who participated and the community more broadly really recognized the value of bringing this intervention together that addressed what they referred to as their home environment, their interpersonal relationships, as well as their minds or their mental health. But there was this broad agreement that it was really insufficient to actually address the root causes of violence. And many recommendations came up around providing services to men, incorporating livelihood opportunities and other factors as well. So some of my key takeaways from this project, which was a really formative learning experience for me, was just the importance of prioritizing a prevention approach, making sure that we're incorporating considerations for the social and contextual determinants of mental health and of GBV, and also making sure that we are from the outset promoting engagement and ownership. I think that is so central to kind of success in any of these more complicated types of interventions and projects. So just before I wrap up, I wanted to highlight just a couple of ongoing projects that are hopefully building on some of our lessons learned from the Nguvu program. So over the past 3 or 4 years, I've been working with HIAS, a humanitarian organization that is focused on refugee protection. They have kind of 4 pillars. They provide legal assistance, They do social protection, which includes GBV prevention and response, economic inclusion, and also mental health and psychosocial support. And over the past few years, we've been working on some projects primarily focused on providing services for Venezuelan migrants. As many probably in the room know, the economic and political crisis in Venezuela has led to over 7 million Venezuelans fleeing the country. And over 6 million of those have remained in Latin America. And as you can see here, a lot within Colombia and Peru and in Ecuador. So our work with HIAS has been to work along key migration routes and to evaluate the effectiveness and implementation of community-based psychosocial and mental health interventions that integrate MHPSS with social protection and economic support for refugees, migrants, and also host communities in these various sites in Latin America. This goes back to this integrated intervention model and just recognizing, and here are some of the common things we've heard about in our formative research around the drivers of mental health problems and what those salient mental health problems are. But we need to think about these mental health conditions within the context of safety and security, discrimination and xenophobia, social connectedness, social networks, and GBV. I also wanted to highlight a few of the mental health conditions or constructs that came up in a lot of our interviews. The first one, malestar emocional, it's not, I think, a very direct translation, but it's the concept of kind of a poor state of emotional being, which came up repeatedly in a lot of our different interviews. Similarly, sadness has come up quite a bit, as has this other construct of duelo migratorio, which is the concept around migratory grief and mourning. And I think these are really interesting because, again, a lot of our mental health interventions are not really designed to focus on migration-related grief and are really much more, I guess, optimized to address some of the more clinical mental health conditions we're more familiar with. So all of these projects started off during COVID. And so that, of course, added another layer to and really exacerbated a lot of these risk factors for mental health problems and caused unique forms of distress as well. Here are just some quotes from some of the qualitative interviews we've done with migrants in Latin America that I think really speak to the connection between mental health challenges and the pandemic. The first quote is from a mother who talks about her fear of actually catching COVID and what will happen if she herself becomes sick and dies, who will ultimately take care of her children. The middle quote I think is really interesting because one of the things we found is a lot of the supports people have received, Venezuelan migrants have received in Latin America, has been through community networks and host communities providing informal supports to migrants who are arriving. But as this person says, during the pandemic, everyone was really stressed and worried, and people were no longer as willing to help because of the fear that they had of catching COVID. And then the final quote relates more to this issue of livelihoods and work opportunities. This comes from a woman in Panama who talks about how before or now during the pandemic, you can't really move. Before you could at least clean people's houses. And now people are nervous to bring strangers into their home. And so they've now lost another source of livelihoods there as well. So one study I wanted just to highlight is we conducted in Panama and in Ecuador, where really the goal here was to start off at the very outset of engaging with communities to design mental health and psychosocial intervention, combined with a social protection element to meet the needs of refugee, migrant, and host community women in 3 really diverse sites in Latin America. And we intentionally selected these 3 different sites in order to understand what is the role of context as we think about the implementation and the design of mental health interventions. The first site is in Panama, so Panama City, as well as 3 communities that are kind of peri-urban communities around Panama City where a lot of migrants have moved. We also worked in Tulcan, Ecuador, which is on the border with Colombia. It's a pretty remote rural town and often a transit point for migrants who are moving further south. And we also worked in Guayaquil, Ecuador, which is a large city, very urban setting, and a destination for many migrants in Ecuador, or migrants from Venezuela. And as part of this process, we went through an initial participatory intervention design process. So we started with the similar formative research that I described in the previous study, where we identified what are the most salient outcomes affecting migrant women in these settings. And those 4 are listed on your right. And then we asked people, what type of intervention would you like to see to address these problems? And pretty consistently what we heard is that women wanted a safe space to come together as a group to address their needs. And the fun part of all of this is kind of what happened in the middle. And so we said, okay, if we have this group intervention that we want to ultimately improve mental health, improve safety, improve connectedness and social support, how would an intervention like this do that? And through this really iterative and kind of community-led process, we articulated 5 key mechanisms that community members felt like would lead to these outcomes. And those are the 5 mechanisms listed here. And then the final step of this process was to say, okay, you want to enhance safety and protection. How would you do that? What are some activities or intervention components that we can bring into this intervention in order to activate that mechanism? And the part of this that was so interesting is we brought in components from evidence-based interventions, existing interventions, and kind of workshopped those with participants, but also had women bring in kind of local practices and processes that they had used or they were familiar with in their cultural context in order to activate these mechanisms. And ultimately kind of combined and massaged and iterated those in order to ultimately arrive at the Entre Nosotras intervention. Entre Nosotras means among or between us in Spanish. It is a strengths-based intervention that is a 5-session weekly intervention that covers the 5 topics listed on this slide. It is delivered by a pair of trained facilitators, so community members, many of whom were actually involved in the intervention design itself, to groups of women in their communities. This was much more of a mental health promotion and kind of protection intervention than it was more of a clinical one. And so we focused this intervention on women in the community who had kind of low to moderate levels of distress as well. And we also ensured that this intervention was adaptable across each of our study contexts. So in this study, ultimately 225 women participated in the intervention. About 2/3 of them were Venezuelan. They were 36 years old on average. About half of them were unemployed. And among those who were employed, most of that was informal labor, so really unstable kind of work situations. And 1/4 of those had arrived within the past year. And then another half, I think, had arrived within the past 3 years. So we looked at their kind of well-being outcomes, a set of selected outcomes that mapped on to those priority outcomes we identified through that formative research process, and examined changes from baseline to end line, which was about 5 weeks, and then 10 weeks later. And ultimately what we found were moderate improvements in the positive mental health outcomes. So we saw improvements in psychosocial well-being, community connectedness, and sense of safety. But again, we observed this pattern where people initially get better, and then after the intervention ends, they kind of return toward where they started, which is something we need to figure out as a field, I think. What we didn't see any significant changes in were more of those problem-focused outcomes. And these are the outcomes that we often measure in mental health research, things like distress, functioning, coping. But what I think was really interesting here was that the groups that we saw the greatest improvement in were those women who were employed, women who started off a bit worse, so had higher distress or lower well-being, which makes sense, and also women who attended more sessions. The reason I say this is interesting is I think the employment piece comes out in two ways here. First, we saw that women who were employed, who had more economic stability, responded better to the intervention. They improved at a greater rate. We also saw that jobs were a barrier to participation. It was women, when they were choosing between whether to work that day or come to the intervention, of course, they would choose work. And so this made this complicated situation where we thought the women who could benefit the most actually had the least access or ability to participate. And so this has led us to a project that's just now beginning, where we are now still working in Ecuador with HIAS to co-design implementation strategies to think about how we integrate an MHPSS intervention like the one I just shared within their economic services. And we're doing that through integrating their MHPSS services with an intervention known as the Socioeconomic Support Program. For those who might be familiar with the graduation model, it's kind of an abbreviated version of that. That starts by identifying and engaging families, migrant families who are in extreme poverty, providing some basic consumption support, so cash or vouchers for food and things like that. And then providing training in how to save money, financial literacy, skills for employment. And families enter into what's called an employment or entrepreneurship school that provides them with the support and skills to ultimately start a business or get a job. And we're currently in this process of like mapping all of the details of this very complicated intervention and trying to think about how and where to integrate those MHPSS supports. All right, the last thing I'll just end with is one more project that actually ends on Friday. So these analyses are literally just being done as we speak. But this is a project, again, with HIAS in Colombia, where now we're trying to understand what are the relative effects of different integration, multisectoral integration approaches as far as implementation and effectiveness outcomes. So here we're working with a scalable intervention developed by the World Health Organization known as Problem Management Plus or PM Plus in its group format. And this is an intervention that's had a large growing evidence base. It's based on cognitive behavioral therapy and a lot of some of the common kind of problem solving skills that are central to a lot of mental health interventions. And what we're testing, like I said, are two models of how to integrate this intervention within protection services, community-based protection services. We're working in 3 communities in the Barranquilla area in northern Colombia, where a lot of migrants have settled. And the first condition we're comparing is what I'll refer to as the traditional task sharing model. And so in this model, we have a psychologist or a mental health specialist who trains and supervises a group of, we'll say, non-specialists, people without formal mental health training, to deliver this intervention. And the people we've decided to train are similar to the Nguvu program. They're women from the community who are working with HIAS and serving as kind of social promoters of protection services. They kind of serve as a liaison between HIAS and the community, do community outreach, and provide kind of some basic services and supports at the community level. And so in our first phase of this project, we trained a group of, I think, 6 to 8 social or community promoters to provide this intervention to groups of women in their community. And I'll consider this kind of a partial integration model because it still has some reliance on that mental health specialist to provide that training and supervision. So in many ways, it's still expensive. It still might not be as scalable because it still requires the time, energy, and salary of a full-time psychologist in order to implement this model. The second condition for the study is what we called the cascading task sharing model. And so here we're further decentralizing a lot of the roles and activities of the psychologist to community members. And this is what we're also calling more full integration of MHPSS into the community-based protection system. So in this model, what we found is, or what we did is we had a psychologist train a group of the women we had trained in the initial phase to actually be trainers and supervisors themselves. And then those community promoters trained a new group of women who were community promoters to provide the intervention to other women in their community, and served as kind of trainers and supervisors throughout that whole process. And so while the psychologist is still a piece of this, they're not requiring or not providing that regular weekly supervision and support, but rather on more of a kind of consultative basis. So what we found, and again, these are very, very preliminary results. So we did observe just between people who received the intervention and those who did not, we did observe an initial reduction in depressive symptoms during the intervention period. But again, we still see that kind of regression back toward baseline, which is something that is important for us to grapple with. But what I think is the really exciting finding here is when we compare those two implementation strategies, those two models of integration, we actually see very similar patterns as far as depression outcomes, where the trajectories of depression among people who received the intervention from community promoters trained by specialists was very similar to people who received the intervention from community promoters who were trained and supervised by other community promoters. So that fully integrated community-based protection model. Our preliminary results also suggest that we see comparable fidelity and competencies among our providers between these two study conditions, which I think is quite promising. So just as far as conclusions, I think there's still a lot to learn, but I think what we have slowly been learning along the way is that integrating MHPSS into other sectors like protection, like livelihoods, seems to be quite relevant to the needs of these communities. We also can see that it's feasible to do that. While there are all of these challenges I shared with funding and organizational mandates and all of these other factors, it does appear that it is feasible for us to design and integrate these services as long as we meaningfully engage and kind of co-design these approaches with people, representatives from other sectors. And we have some preliminary evidence that the quality and effectiveness of these mental health interventions can be maintained when we integrate them within other sectors, and that we don't kind of dilute the mental health effects by transitioning them into other sectors and spaces and systems. There's still a lot we need to know, like how do we actually sustain the benefits of these interventions? How do we reconceptualize these interventions so they might not be kind of an insular process, but we can provide some ongoing support to people to maintain those benefits? How do we think about the kind of structural and interinstitutional determinants, which we haven't really captured here? There's a lot we still need to know and a lot of questions, which is why I would like to end by saying thank you so much for your time. And I'd love to hear your thoughts and questions going forward. I will just say also big thanks to our teams. These are some photos from our different research teams on these projects. And for me, by far, the best part of this work is building relationships and the collaboration. So I can't thank these people enough. Thank you.
We have a question on Zoom from Melody. So she was asking if you know what is the reason, or if you can speculate why in the Nububu study you would see such a high staff turnover.
That is a good question. So I think we saw high staff turnover at multiple levels. So as far as the staff, I kind of the people most involved in implementation were our facilitators, so the counselors we trained. The main cause of turnover there was actually resettlement, which is a good reason for turnover to happen. There was active resettlement happening in the beginning stages of the project. That was actually the largest reason that participants dropped out of the program as well. But at slightly higher levels, and Kaveh and I were talking about this earlier, I think it is really hard to do this work. And I think in a place like Nyarugusu, a really protracted, complex context, a lot of the staff, kind of the field staff, are really burnt out. And so you saw a lot of turnover, people moving between sites. That was quite common. Unfortunately, we also saw that at the higher levels, one of our initial partners on the project had another job opportunity and so ultimately left the organization. And that I think happened less frequently, but it was pretty, had a pretty big impact on our program because I think she was really the champion of this approach within her organization at the headquarters level. So I think there are a lot of reasons for turnover, but I think it's really hard work and common to see these levels of turnover at the field staff level. Yeah.
Can you ask questions?
Yes. I just had a question similarly about the Google intervention, and that in the end that you found that it was better to not organize outcomes or depressive symptoms or these symptoms via, PTSD, depression, anxiety, but rather Kofu, Huzuni, and the third. I just don't want to butcher that one. I'm wondering, moving forward, how do you, if you wanted to examine any other kind of conditions in relation to mental health, like would you use that as the reference? And then essentially, how do you use that moving forward as your measurement?
I know, because it's probably going to change not only across different populations, but also over time too, you know? It's a really good question. There's a paper we published on this, and I'm glad you're asking about this, because surprisingly, it's one of the things I'm still fascinated by was that finding, or that kind of triangulation of information. One of the ways that we've thought about this in our group is, I think there is still value in using measures across multiple contexts for comparison's sake. But I think we need to be more deliberate about incorporating items that reflect local concepts of distress. So there's been some work by Emily Harris and others who have mapped all of the depression measures across the world and how they've been used, and identified some unique items across different contexts. And so one of the strategies they suggest is try to find a core set of items that you think are helpful to measure across multiple studies and across populations. But through this formative research process, identify some items that are missing that you can then kind of integrate into your measures. I don't know that I would recommend, unless I was working in the very same context and could validate that these three concepts of distress were still appropriate, I wouldn't necessarily take those three idioms and apply them in different places, right? Because I don't think they're universal or even kind of static. I think these things are fluid and quite dynamic. So we have to kind of think more flexibly about how we design our measures to enable kind of both of those comparisons. Does that answer your question?
I have a very small follow-up.
Please.
Sorry, this is very applicable to my work, and that you might find, for instance, that somebody else has used PCL5 or the trauma questionnaire in that country. But essentially what you're arguing is yeah, it might work at this level, but if you really want to get a more accurate estimate, it's incorporating kind of that variation that's based off cultural or the local context interpretation of these conditions.
Totally, yeah. And I think, one of the things that's hard too is when we looked at before we did that exploratory factor analysis and just allowed the items to correlate as they may, we did look at things like internal consistency and the kind of confirmatory factor analysis, how well did the data fit depression, anxiety, and PTSD. And there were no major red flags, but it did seem that after doing this EFA approach, that actually the data fit the concepts we heard about in the formative research much better or more naturally, perhaps. And so I think even if something has been validated elsewhere, I think it's always still good for you to kind of explore what is missing and how can we think about balancing those two approaches. Yeah.
I have two questions related to the community's response to these mental health interventions. The first one is, I guess, on how the people perceive these interventions to be effective or not, and especially coming in, I guess, as people from the northern or more developed countries, are there any instances or risk of cultural appropriation of what mental health issues were in the local context, especially in, I guess, among some of the refugee communities? Patriarchy might be a lot more of an issue, and certain practices they have is quite foreign to us. So I think that's the first question, and how you were able to navigate that while trying to measure mental health conditions. And the second one is on, I guess, once interventions end, what is that transition process like, and how is the community able to, I guess, move forward with it or continue to benefit from it even if programs end?
I love both of these questions. So taking the first one, I think the question around how communities respond, I think is one that I've evolved or thought differently about over time. And it's really kind of what I've used as kind of my guide in thinking about future projects and steps. I think it ultimately comes down to who has the decision-making power and in what the intervention looks like and how it's tested and evaluated. I think with the example I gave from Ecuador and Panama, where we kind of said okay, design the intervention based on what fits, we'll offer some ideas, but the community really did design that. I think there are a lot of people who are very skeptical about that approach because there is this interesting debate, I think, in the field right now between like the holding kind of true or kind of maintaining the fidelity to what we have evidence for and relaxing that toward more of a kind of cultural relativistic approach. And I have swung a little bit more in that direction recently and think that we have kind of the potential to do less harm by transitioning some of that decision-making power to the community themselves. And I think is that intervention as effective as something else? I'm not sure. One of the things that I didn't actually mention here is a part of that study design, we integrated one external component and did kind of a comparative effectiveness trial comparing two versions of the intervention, one that was enhanced with this WHO intervention and one that was the community design version alone. And we actually found there was only one indication that there were any differences in how people responded to them or people's trajectories as far as their outcomes. So I think this is a big debate at the moment, but I guess I am leaning toward if you enable and facilitate the decision-making power to happen within communities, I think you run less of a risk of some of the points that you brought up. But it is, yeah, there's a lot of debate on that topic. Your question around sustainability is also a really good one. So the final project that I mentioned, the one in Colombia, where we kind of trained these different groups of providers and counselors and trainers and supervisors, the feedback we got at the very end. So we had some focus groups with our counselors and our trainers and supervisors to say to get their feedback, but also to go through this sustainability planning process, where we actually asked them, what would you need to sustain this program? Is it money? Is it space? What would that look like to you? And how would you design this going forward? And it was interesting. And we're actually thinking of talking with the donor about this for the next stage or the next iteration of that project, where what the community wanted was some kind of formalized process of seeing themselves as a community-based organization. And so, which I thought was really interesting, because in some ways, providing the skills and the infrastructure for them to organize and be seen as kind of this entity within the community that has this set of skills and that they can then kind of leverage in different ways with the government or with different organizations, I think is really powerful. And so that's actually what we're thinking at this stage is, how can we better facilitate that organization and mobilization of these women into groups that can then kind of sustain the project in the longer term? But I think there are not a lot of good examples of sustainment of these types of interventions for the reasons you're probably alluding to.
There is a couple of additional questions here. Abre, do you want to ask the questions? Well, otherwise I'll just read. So she says that if you would share some details of about how GPM Plus participants were selected and how groups were formed, and if did women know each other, and if they knew or did not each other, do you think if it influences the impact on the intervention?
Good question. And yes, I rushed through that example, so didn't go through those details. So for the last study with the group PM Plus model, there were selection criteria to identify women who are experiencing some level, a moderate level of distress and functional impairment as well. The women identified actually came through two sources. One was women who had sought support through HIAS, and then HIAS referred them to the program. The other was through the facilitators or the counselors themselves. So them kind of referring women to HIAS so that they could participate. And so it was kind of two-pronged as far as through the humanitarian organization as well as through the community. The second part of that question was, about how the groups were formed. So the groups were formed within those three communities. They were kind of far apart from each other. And so it is likely that women knew each other, or some women might have known each other beforehand. I don't think that was the case all the time. We're still analyzing our qualitative data, which is where we would be able to answer that more directly. So I can't say for sure, but what I will say is actually from the Nguvu intervention, initially we had assumed that it was better to keep groups separate, not to have kind of friends or people who knew each other in the same groups, especially when talking about IPV. And what we found, I guess, was the opposite, that women actually wanted to kind of maintain their existing networks when they participated in the intervention. The exception being is if there was some sort of generational difference. So younger women did not want to be in the same group as an older woman for kind of cultural reasons. And so we had to stratify the groups by age, but also it was actually preferred for women from the same women's groups to participate in groups together. That answers the question.
Okay, and there is another question from Lami. So first, she thanked you for the great work and presentation. And then she said, if you can get the thought as the best practices and your recommendation as to how to evaluate the added value of multisectoral interventions that integrates mental health with other services, including cash transfer in humanitarian settings.
Yeah, that's also a really good question. So based with my collaborators at HIAS, they actually just formed a working group through the IASC, the Interagency Standing Committee, on MHPSS, cash and livelihoods. So I think there's a lot of energy and focus on kind of understanding how to integrate. But as far as how to evaluate, I think the next big step is thinking about is mapping and evaluating outcomes, both economic and mental health outcomes, and determining whether that integration actually improves those outcomes synergistically more than we would see if they were operating independently. It's a big project. I think that's where we hope to go with this project in Ecuador, but I think that's a ways down the line. The second part of that question, in addition to evaluating, was, did I miss something?
Yeah, basically, yeah, integrating with the cash transfers in humanitarian settings. So that was
This is Dr. Joma Lamis, the one who just asked the question about the integration. Dr. Greene, I really appreciate your thoughts. And the reason I was asking about the recommendations, because you said it can be rather messy to work with the integration of services and sometimes just getting the buy-in. And the reason why I'm asking that is because we're trying to do this work in Lebanon with Syrian refugees and Lebanese host communities. And one of the major challenges is sometimes you have a combination of things going on. We have some services that are already integrated and nobody is doing any evaluation, and it's kind of some form of integration. And then some that are looking at it and kind of thinking why they added challenges and barriers, and let alone also the identity of the refugees that take the cash transfers that may not want to be known for the mental health, and vice versa. So I guess the question was really multifolded. Is one, how do you overcome those challenges to get the buy-in for those different services to talk to each other and to do that? And when it comes to evaluation, and maybe this is a conversation beyond today, but I wanted those thoughts about the kind of behind the curtain.
Yeah, and I'd love to talk more. So please reach out. I think it's, as you're saying this, I mean, it's funny because one of the challenges that we've had in our early attempts to do this is to actually get, even within the same organization, the economics team and the MHPSS team to speak the same language. And I think ultimately what I've arrived at is, I think a big takeaway for me is ensuring that at every stage in these projects, making sure there's kind of equal representation across sectors, from the design through the implementation, through the evaluation, so that you kind of are aligned throughout the entire process. But as you're talking about evaluation, it reminds me, one of the things that we've come up against is even just the way we operationalize some of the key outcomes. So for example, the economics team, one of their main outcomes of this intervention is community integration, promoting community integration through this economics and livelihoods intervention. And so we've been trying to figure out, between the MHPSS team and the economics team, how do we measure that? And what we've discovered is actually our kind of the root of what we think community integration is totally different. And this comes down to a conversation we had even about social support, where the economics team has really been focused around instrumental support. How many people do you have in your network who can provide a loan if you need cash for something? Versus the more traditional mental health intervention is like, how many people do you have to talk to or support you when you're having trouble with something? And so I think even just aligning what we're evaluating as far as our outcomes across sectors can be quite challenging. The other thing that we've kind of come up against that might be less complex with cash than some of the other interventions is just the complexity of mental health interventions and the economics interventions make it really, I think, hard for us to isolate impacts, right? And also when we're thinking about, to your point around participation, all of the people participating in an economics intervention might not be appropriate for the same type of mental health intervention. And so how do we think about, like, what are we really evaluating then? So I think it's quite complicated and something we haven't fully navigated ourselves yet, but I'd love to chat more as you're grappling with this as well. Thanks for the question.
There is a question by Charles. Do you want to ask?
Yeah, sure. Yeah, thank you. Thank you, Professor Greene. I think this is really super important work, and it's right on the cutting edge of mental health and psychosocial support and localization. And I'm a sociologist, and I've been 9 months into 12 months of ethnographic work asking mental health workers about how they're localizing their work and the struggles that they face as they're working with refugees in spaces. And I think what you're saying about like having these initial assessments about the drivers of mental health and how they should be culturally situated is super awesome. And I think it's becoming more common, but the examples that you gave in Panama and Ecuador where the actual interventions are culturally based, I think that's still something that there's a lot of space to be, a lot of growth. I know like BRAC, IRC, and a lot of other organizations are all kind of using the same interventions. So when I talk to these kind of small and medium-sized organizations and the people who are working within them, they have a lot of struggle because these workers are really dedicated to supporting refugees. But then when they're trying to localize the work, they don't know what to do with their expertise, right? So they're mental health and psychosocial support experts, right? But if the intervention should be locally based and ones that are determined by the target community, they don't know, are they just creating space, right? Or do they actually have an expertise that they're bringing to the table that then they can, you know, talk about with the refugee community? So I was wondering if you could talk a little bit about how people who are struggling with the localization of these programs or want to do such good work, how do you see the line of like where your expertise comes in, whether it's just a political project of creating space for people alongside giving them living support, things like that. So it seems like a complicated normative space. I was just wondering if you thought about that and any advice you could give these experts.
Oh, advice. Yeah, that's a good question. Thanks for those thoughts. I mean, so our partners, I guess my closest partners in both Ecuador and Panama are themselves psychologists, but they come from the world of community psychology, which is a discipline that I'm not as familiar with here in the US, but I think is something that is much more robust in Latin America, for example. And I think more amenable to some of these, I guess, more collaborative approaches to designing and thinking about mental health interventions. I mean, I guess the discomfort with deviating from kind of what is evidence-based or what we think is evidence-based. For me, I think the role maybe of the specialist is first to just making sure that the interventions themselves are safe and we're not kind of creating a situation that could lead to harm. I think that is kind of paramount and kind of a good starting point for their role and something that these people have the expertise to do and the knowledge. I mean, I think a lot of it, and this is a challenge I've been talking a lot with Hayes about, is like these formative phases take a year, and it's a lot of building relationships and a lot of building trust. And sometimes humanitarian organizations don't have that luxury of taking a year to go through this process. But I think the benefit and where we got was a really nice place where it was an exchange between the community and the psychologists and our team that felt really horizontal. I think it felt really like they were collaboratively working toward an intervention together, as opposed to taking something and tweaking it to fit here and there, which I think is what happens in a lot of adaptations. But I think it takes time. And so I don't know what the solution is in a context where you don't have that luxury. I think that is tricky. And I don't know if I have an answer for you on that, but I think that there still is a very valuable role of specialists and kind of being facilitators and guides and being part of having a seat at the table, but not necessarily driving it. I hope that answered that question.
Yeah, that's great. Thank you.
Yeah, happy to talk more too.
Professor Claire Greene, thank you so much for
Thank
this
you,
great talk
Kevin.
and also great question.
Thank you so much, everyone.